Thank you for joining and taking the time to be here today. Welcome to the webinar, Should I Take This? A conversation about medication hesitancy. My name is Ruth Ackerman, and I'm the Director of Professional Development at the Ontario Pharmacists Association, and I will be your moderator for this evening. So on today's agenda, I'll just give you a brief introduction to OPA for anyone who's new, and then I will introduce today's speakers, who will be guiding you through today's presentation. We'd love to hear from you, so put your questions in the Q&A, and at the end of the presentation, there will be an opportunity to ask questions, and I know you'll have questions. So for those of you who may be new, OPA is Canada's largest advocacy organization and professional development provider for pharmacy professionals across Ontario. With over 10,000 members, OPA is committed to enhancing the pharmacy profession and excellence in patient care. The pharmacy profession has played and continues to play a critical part in the vaccine rollout and battle against COVID-19. As of August the 9th, 2021, over 3.3 million COVID-19 vaccine doses have been administered through Ontario pharmacies. This is a significant feat and demonstrates the integral role of pharmacy professionals in Ontario's healthcare system. At OPA, we applaud the efforts and dedication of all pharmacy professionals. Without the support of our members, OPA would not be able to continually advance the pharmacy profession. Our members make what we do possible. Thank you to all pharmacists, pharmacy technicians, assistants, interns, pharmacy and students who are working on the front lines and have stepped up to protect our communities and Ontarians. I'd also like to say thank you to Takeda Canada for their sponsorship of this evening's webinar. So now to our speakers. So as the speakers set up, I will let you know a little bit about them. So Jamie, you can take it away. So first, Dr. Lawrence Martin. So Dr. Martin is an associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. He completed residency and fellowship training at the University of Toronto, yay, and has completed 2 terms as Director of Psychiatry Resident Training and 1 as Vice Chair Education in the Department of Psychiatry at McMaster. Sorry, Lawrence, I'm a U of T grad. Dr. Martin has held a variety of clinical administrative roles, including Assistant Chief of Psychiatry at St. Joseph's Healthcare and Clinical Director of the Regional Mood and Anxiety Disorders Program at St. Joseph Healthcare. Dr. Martin's practice has, over the past 10 years, come to focus principally on adult ADHD, and he is actively involved in education to help clinicians come to a better understanding of the marked impact it has on an individual's lives and on the response to treatment of comorbid illness. Jamie Keller is an associate professor, teaching stream, and associate dean academic at the Leslie Den Faculty of Pharmacy, U of T. Yay! She received an honors Bachelor of Science degree in Human Kinetics from the University of Guelph, followed by a Bachelor of Science in Pharmacy and a Doctor of Pharmacy degree, both from the University of Toronto. Currently, she is a PhD candidate in the School of Health Professions Education, Maastricht University, Netherlands, where she is using, oh boy, Foucauldian critical discourse analysis to study pharmacist professional identity. In addition to her education, she's a licensed pharmacist in Ontario. Professor Keller's practice areas in the field of mental health, specifically in inpatient mental health. Dr. Keller is an award-winning educator, having won the University of Toronto Early Career Teaching Award and the Association of Faculties of Pharmacy of Canada National Award for Excellence in Education. So take it away, Dr. Martin and Dr. Keller.
Great, thanks, Ruth. Hi, everyone. Welcome to our session this evening, which we've entitled, Should I Take This? A Conversation on Medication Hesitancy. These are the disclosures that we always start with for Dr. Martin, and I have nothing to disclose. So over the next little while, we are going to cover a lot of ground. Some of it will be clinical knowledge and a review of some of the issues around ADHD, which will be interspersed with conversations between Dr. Martin and I. And so you'll get all sorts of knowledge as well as opportunities to hear us have conversations. We're going to talk about predominantly ADHD tonight. However, many of the things we'll discuss will be applicable to other mental health conditions and chronic diseases. And so you'll be able to apply it more broadly, but our focus tonight will be on ADHD. So we'll review some of the pathobiology and clinical features, and we're going to move into discussing a number of components of ADHD, and we're going to leverage all of Dr. Martin's expertise, and we'll also connect that back to the role of the pharmacist. And so I'm going to turn it over to Dr. Martin to get us started.
Thank you very much. I can't see. Just a moment, excuse me. Okay, there we go. Okay, it is a real joy to be able to speak to pharmacists tonight. I practice principally psychopharmacology, and so have a great love for the work that you do and great admiration for the work that you do. ADHD is an incredibly interesting problem. I slid into it about 10 years ago, having worked the first 15 years in mood disorders in a tertiary mood disorder clinic. I still work there, but my practice has moved over now to focus on ADHD. And the principal reason is because of the tremendously high degrees of comorbidity between mood disorders and ADHD. And we'll talk more about that a bit later. But right off the bat, if you have, for instance, somebody who's coming in and getting multiple antidepressants filled, the chance that that person, if they're not responding to 3 SSRIs, for instance, the chance that person has ADHD is 34%. And the problem with ADHD is it is generally not recognized by psychiatrists or by family doctors. The reason it's not recognized is because psychiatrists and family doctors, for all purposes, get no training in adult ADHD. They have a spin through childhood ADHD, but the programs do not have any curriculum of note dealing with adult ADHD, so it's missed. And the general comment, I generally describe ADHD as the syphilis of mental disorders. Now, what that means is, of course, in the era when syphilis was very prominent, it was called the Great Masquerader. And syphilis would present as neurological disorders, mood disorders, pneumonia, a feast of different disorders. The underlying problem was the syphilis. And you could treat all of the sequelae and get poor results. You had to treat the syphilis to get good results. And that's exactly the problem we have with ADHD, is it's a primarily neurologically based disorder that leads many people who have it to develop anxiety disorders and mood disorders. That's what they present with. And they get treated for their anxiety, they get treated for their depression over and over and over with poor outcomes. And the reason they have poor outcomes is they're not addressing the fundamental disorder, which is the ADHD. And when I came to realize that, my practice changed fundamentally, because now I could, by doing a proper history of what they were like as kids, start to pull out the people where the reason you're not going to respond to an SSRI is because you have ADHD. People with ADHD don't do well on SSRIs generally. We'll come back to that later. What is ADHD? First of all, it's real. You know, you'll often hear people say ADHD doesn't exist. People just need to learn to behave better. They need to stop being so impulsive. They need to grow up. And that's kind of like saying pneumonia doesn't exist. People just need to stop coughing up bloody sputum. Seizures don't exist. People just need to stop falling to the ground and shaking. The basis for ADHD is delayed maturity of the regions of the brain, particularly prefrontal cortex, that regulate our behaviors, that regulate our attention, regulate our emotional reactions, and that mature as we get older. When you think about a kid, they don't have any real, a young kid, 2-year-old, 3-year-old, they don't have any control over their emotions. If they're sad, they cry. If they're excited, they run around the room, get all jumped up. If they're happy, their smile is enormous. If they are doing something, if they're interested in it, they will be all in it. They'll play with the dollhouse for hours if they're interested. But if they're not interested, their brain goes looking for something interesting and they can't focus at all. So the problem with ADHD is that it's delayed maturity, in particular of the prefrontal cortex. The brain develops back to front. The last part of our brain that matures is the prefrontal cortex. And it doesn't really fully mature until a person's in their mid-20s. And the prefrontal cortex is the part of your brain that says, what could possibly go wrong? And then answers that. It's the part of the brain that says, I would like to go out and get drunk, but I have a test tomorrow. So it's the mature part of the brain. And if we have kids, as the kids get older, they develop more and more self-regulation skills. They go from having no self-control, including fecal or incontinence, to learning to walk, to learning to speak, to learning when it's appropriate to say certain things and to not say other things. When something that's upsetting should lead to a tearful episode, or when it can be gone as I'm sad, but I don't need to burst into tears. And as our kids get older into their teens and into their grade 12 and on into university, they develop a lot more self-regulation skills. That's why they can go off and be on their own. Lots of kids, of course, run into problems when they go to university because they go to school, they're 17 or 18, their prefrontal cortex, their self-regulation skills aren't developed fully. And they essentially go to university and leave their prefrontal cortex at home, the adult part of their brain that says, do this, don't do that, think of the consequences. So the regions of the brain that are of most interest in ADHD are prefrontal cortex, anterior cingulate. And the key again is the prefrontal cortex is the adult part of the brain that allows us to make a plan, to work towards it systematically, allows us to prioritize what we do to get to our goals. It's the part of the brain that helps us stay organized. And it's the part of the brain that regulates our emotions. And again, the problem in ADHD is a person with ADHD, their brain is developing self-regulation skills more slowly than their peers. So most kids with ADHD, they may have the intellectual ability of a 12-year-old, but if they have ADHD, they have the emotional regulatory skills and the social skills of an 8-year-old. And we'll take a look at the implications for that in a second. ADHD, again, it's a neurologically based disorder. It has the highest rates of heritability of any psychiatric diagnosis. And ADHD, because it's a problem of delayed self-regulation skills, delayed brain development, as people go into their adolescence, most will still demonstrate the ADHD difficulties with their behaviors. And it was thought, or people commonly believe, that you grow out of ADHD. By the time you're an adult, you no longer have ADHD because you've grown out of it. The sad reality is that anywhere from 50 to 80% of people with ADHD continue to have significant symptoms into their adult years. The problem is services disappear.
So since there are that progression that ADHD lasts into adulthood, are there similarities in how children and adults present with ADHD that pharmacists should be aware of? or are the actual physical manifestations or clinical manifestations unique in the different age groups?
No, they're very similar. I mean, they have different manifestations because people have different levels of responsibility. And of course, an adult, by the time they're 25, their brain is fairly set. And so they will have developed lots of self-regulation skills, but they won't have the full set. The problem of restlessness, one of the three traditional legs of ADHD, the restlessness tends to go down, and people tend to grow out of that to a significant degree, though not entirely. They still will fidget, they'll doodle, they still have to be doing something when they're sitting in a lecture hall or when they're at meetings. Generally, they doodle or shake their legs. But that tends to improve. The problems with impulsivity, just doing what you're thinking and not thinking of consequences, the problem of being able to control your emotional reactions, those improve, but those tend to persist well into adulthood. And so the presentation is more subtle in an adult at the counter than a kid, but I guess kids don't really come to the counter, do they?
On occasion. Okay.
So the consequence, and this is just again to give you the general picture of the problem with ADHD, is if you can't regulate your emotional reactions, if your ability to read the social setting is stuck 4 years behind the peers, if you have poor social skills, if you act differently from other kids, then what happens? Well, school is a giant Lord of the Flies exercise. And if you don't fit in, you get ostracized, you get bullied, and you get isolated. And it's awful, the percentage of adults I see with ADHD who were cast out of the herd as kids. They didn't have many friends. They didn't belong. They didn't know why. They got bullied. They didn't know why. But it was because they were just different. They were just different because they didn't know how to behave appropriate to their age. And so all of those isolative consequences follow. And then, of course, when you are cast out and when you're living a life not understanding why people are rejecting you, you tend to develop a lot of anxiety. You tend to have very low self-esteem. You don't think highly of yourself. You lack confidence because you keep failing. And it has long-term effects which lead to other psychiatric disorders.
So how does the emotional impact of ADHD that you just described how does that impact patients actually seeking treatment and even adhering to treatment, thinking about how much they go through, particularly the social isolation to a certain extent must have a huge impact?
Yeah, the problem is that most people blame themselves and have been blamed. They've been called lazy, they've been called stupid, all kinds of things, and they've internalized that. So they tend to not come for treatment. They don't recognize that these are features of ADHD. They just think they're not organized and they're not very good at things. And they have low self-esteem. They also, interestingly, most people with ADHD are very sensitive to criticism and to feelings of rejection, to negative comments. And so a real block for some people getting assistance is if a parent doesn't believe in ADHD, or if a parent is critical of a kid who wants help for ADHD, or an adult, if the wife or husband is dismissive of ADHD and critical of it, and they feel rejected by it, they will tend to not come for treatment, because one of the hallmarks of ADHD is people are very sensitive, and for the most part, they don't want to let their family down. And so as a result of their emotional sensitivity, they tend to not come for treatment, especially in the face of any adversity. Now, there's a flip side to this, and that is an inherent part of the ADHD brain is also for many, if not most, to be politely contrarian or oppositional. One of the hallmarks of ADHD is that people, if you're told to do something, you are absolutely not going to do it. And so if the doctor is patriarchal and tells the patient to what they should do, a good chunk of patients will therefore decide not to do it. And when you're working with ADHD, because the ADHD brain is naturally contrarian, takes the opposite stance, picks an argument, won't go into why that is, but it's seeking stimulation. So when you're working with somebody with ADHD, you are best not to tell them what to do in any kind of directive way. You're better to advise them or say, you know, well, I wonder what would happen if you did do this. I wonder what would happen if you tried the medication. They're less likely to resist if they're not told directly, but if they simply put out there as a question, I wonder what would happen. So open-ended kind of instructions.
Yeah, that's great.
Last comment is the emotional part really affects adherence in that people with ADHD tend to be driven by their emotions. And so if they wake up in the morning and they don't feel like taking their medication, there's a good chance they won't. If they feel like taking it, they will. If they don't feel like it, they won't. And so adherence can be a problem because they are so often just feeling driven.
Yeah, interesting. And I think the stigma is huge. And I've certainly met with a lot of parents that struggle with starting medications, which we're going to talk about, particularly because the label of ADHD carries a hefty weight. And often I've heard folks be concerned that it's a label for bad behavior or bad parenting. And those things, I think, also carry a burden to the family as well as young patients that then also internalize that into adulthood.
Yeah, and I think that's why it's so important that everyone understand that this is a neurologically based problem. It's measurable. When you look at the MRIs, functional MRIs of people with ADHD, the cortical activity in the areas of self-regulation are very underdeveloped compared to their peers. So the more that it can be reinforced, you know, this is a real medical problem. This isn't just bad behavior. This isn't poor parenting. This is how a person's born and how they're wired. And it is not the fault of the parent. It's the problem of how they're wired and how their brain works.
That's really
It's also
helpful.
very important that it has nothing to do with intelligence. I have a significant number of patients who are gifted ADD. So their IQ is in the top 1%. They're really smart, but they haven't accomplished anything because they can't get their stick on the ice. They can't organize, they can't follow through.
Interesting. Comorbidities.
So the consequence of being ostracized in that you have ADHD, but over time, because of the social impact and because of your poor performance, people tend to develop generalized anxiety disorder, social anxiety disorder, and dysthymia. If you look at people with social ADHD, there are very high rates of social anxiety disorder and very high rates of chronic low mood. Now, if you have anxiety or you have chronic low mood, the natural self-medication is to drink, is to smoke pot, to make yourself better. And because lots of people smoke pot and it reduces their anxiety, they get into substance use. They also get into substance use in high school because if you don't belong to any of the groups or cliques, there's one group you'll always belong to, and that's the potheads. The people are smoking pot. You can be as weird can be. You'll still fit in there. And so people gravitate towards pot because it does often help their anxiety. And some it helps them focus because of the dopaminergic effect. But the main thing is they finally belong. And then they're locked into this relationship where substance is the way that they fit in. And that's pretty detrimental. And this is the really important, this is how I got to ADHD. 4 out of 5 patients with ADHD have a comorbid disorder. And they present to their doctor usually with the comorbid disorder, with the anxiety disorder, with depression. The problem is, as I said earlier, when you use standard treatments for someone with ADHD who has anxiety or depression, the treatments tend to not work very well. And they don't work well partly because people with ADHD have problems with adherence. They have trouble remembering to take their meds. They have trouble remembering to get their prescriptions refilled. But a big reason for their non-response to standard treatment is the standard treatment for anxiety and the standard treatment for depression is SSRIs. The problem is when you increase serotonin, you reduce norepinephrine and dopaminergic firing. And when you have ADHD, your central problem is that you have reduced dopamine and norepinephrine activity in your prefrontal region. So patients who have ADHD and then get depressed, they're given SSRIs. The elevated serotonin further inhibits their dopamine and norepinephrine, and they tend to have a poor antidepressant response. Again, Martin Katzman looking at people who are referred for treatment-resistant depression, no mention of ADHD. When you went back, did childhood surveys and a careful analysis, again, 34% of those with treatment-resistant depression had ADHD. The reason is they keep getting SSRI after SSRI. And when Martin broke down what predicted the ones who had ADHD, the number of SSRIs the person had been on was one of the factors that predicted whether they had ADHD. So you'll see the patients coming with depression and anxiety. And the problem is, if they're not responding to SSRI after SSRI, there's a good chance they have ADHD. The problem is the family doctor or the psychiatrist won't have thought of that.
So is there a question that a pharmacist could ask to determine whether or not they should refer somebody? So sometimes patients that don't respond to medications end up seeing multiple physicians thinking that they've got the wrong drug or the wrong doctor, but they use the same pharmacy. So it's not uncommon for us to see patients that have tried and failed, as you've said, multiple SSRIs for either depression or anxiety or both. And so at a certain point, is there something that a pharmacist could inquire about that might suggest that it's worthy to be assessed for potentially an underlying ADHD, and let a patient know that in a way to be more curious than obviously offering a diagnosis?
Yeah, and it's interesting. I thought about this. And I thought about the possibility of a pharmacist giving an ASRS to patients, but I don't know if you can do that kind of thing or not. Can you do that?
So we do lots of screening tools, and certainly we do within a community pharmacy a PHQ-9. You can do a GAD-7.
Okay, so
absolutely.
So absolutely, give the patient, if you can get an ASRS. So it is a very simple one-page assessment tool for ADHD. There are 6 questions at the top, and I think it's around 15 questions at the bottom. In the top section, the boxes are shaded. And if the person ticks in the shaded area in 4 of the 6 top boxes, there's over 80% chance they have ADHD. Now, it can be wrong. If a person's very depressed, it can look like ADHD. But, if you had ASRSs there and you said, take a look at this, this may be a reason you're not doing well, is the serotonin might not be good for you. And if they fill out an ASRS, again, you don't even have to look at the whole sheet. The top boxes, if they tick 4 out of 6 in the shaded area, there's a very good chance they have ADHD. And you could direct the person back to say, you know what? Maybe you should read up a bit, look at the internet a little bit about ADHD and see whether that seems to fit with how you were when you were younger and how you are now. If you've got problems with organization, problems with finishing things, problems with moodiness, then it could well be that ADHD is there, and then you have to use specific medications for it. But no, it would be an enormous benefit if the
That's great.
pharmacist gave the ASRS out to test that
Absolutely, and
water.
it would guide those patients that might benefit from further follow-up with their physician.
But I think
That's
it's
great.
also really important to direct them to read up about it on the internet.
Yeah, absolutely.
Ignore all the sites that say it isn't real, it doesn't exist. But
Yes.
look at the ones that just describe the kind of symptoms and experiences. And people will usually recognize very quickly whether those descriptions resonate with them or not.
Yeah, absolutely. I've had many experiences of working with adolescents who has a parent that when a child gets diagnosed, they recognize themselves as children and they never received a diagnosis, but going through the process with their kids triggers in many of them a recognition that, hey, maybe I have this as well.
Yeah, it's 100%. I mean, I was going to say that, thank you, I forgot to, but it's inherited. So if you're filling a prescription for a kid with ADHD, one of the parents has it. You know, and usually if you see both parents, you'll be able to identify which one, but one of them's going to have it. If you're filling it for an adult, they need to be mindful, they need to watch for it in their kids.
So what's the approach to treatment then for comorbidities? Because if we're treating what looks like depression and potentially anxiety and often substance use disorders, and there's this underlying ADHD, if you go back and get a diagnosis and treat the primary ADHD, does that resolve the other psychiatric comorbidities, or do they both need treatment still?
Yeah, they usually both need treatment, but the general approach is treat the worst first.
Okay.
So if a person's in the midst of a pretty severe depression, if they're not getting out of bed, if they're not showering, they're not brushing their teeth, if they're not taking care of themselves and they can't get to work, you go for the depression first. But the key thing there is don't go for the SSRI first. And even don't go for an SNRI first, because the great mythology about SNRIs is that they're dual action agents. And the reality is that duloxetine is still 10 times more potent on the serotonin system than the noradrenergic system. Effexor doesn't even begin to affect the noradrenergic system significantly till you're at 225 milligrams. It's an SSRI up till then. So if it's depression, the medication that they should be on preferentially is Wellbutrin, bupropion. You know, in the largest network analysis ever done, bupropion was the second most potent antidepressant. It didn't make the final cut because of questions about side effects. I find it to be very well tolerated for the most part. But the first choice in depression, if you have ADHD, is bupropion. Other alternatives would be Fetsima or potentially Trintellix. The reason for Fetsima is 2 times as potent on the noradrenergic system as on serotonin. And the vortioxetine, Trintellix, is of interest because though it has significant effect on the serotonergic system, because it affects multiple receptors, it doesn't inhibit dopamine and norepinephrine firing. It actually still enhances firing across all 3 of the major catecholamines. So if someone has ADHD and is depressed, the depression should be treated with one of those antidepressants preferentially. Or if you've got a really old psychiatrist like me, dizipramine, which is purely noradrenergic and is a great antidepressant. If it's a low-grade depression, they're just grumbling along or they don't enjoy much, but they're functioning, then I would say go with the stimulant first and see if improving their level of function is all they need to have their mood improved. Bipolar disorder, high rates of comorbidity. And most people would think, well, you can't give a stimulant to somebody with bipolar disorder. That's just not true. I treat lots of people with bipolar illness and ADHD. The data is very convincing, including large community-based surveys and the Danish cohort study. If a patient is on a mood stabilizer, there is no increased risk of them going manic with a stimulant. If they're just given a stimulant, there's a 9-fold increased risk of them going manic. So the key there is if bipolar, absolutely the ADHD should be treated. but you have to get the atypical antipsychotic mood stabilizer on board first, good levels, then you treat the ADHD. Substance abuse, still, treat the disorder. Very, very high rates of ADHD among substance abusers. And you can still go ahead and treat. The key there is generally with treatment is only use long-acting agents. Don't use anything that comes on fast and gives you a punch.
Excellent.
So those are general guidelines, but treat the worst first.
Fabulous.
We've been through this a lot, so I'll basically just do a quick scan. The pattern for development with ADHD is, first of all, it's a hardwiring issue. It's there from the earliest ages. It may not show up till people are in middle or high school, because if they're smart, they've developed their workarounds and their school marks won't show it. It won't show up if they're girls, because girls often don't externalize, they internalize. And so girls with ADHD are often quiet and anxious and daydreamy. So they don't get identified. They don't get picked out because they're not creating a problem in the classroom. But generally, it's there, and their behaviors will be inappropriate. They will not act their age through school and into adolescence. They get into more behavior problems in adolescence and more difficulties with social interactions, because adolescence is when everything becomes horrifically catty, if you're a woman or a kid, a girl, and they feel that ostracism even more strongly. And that's when they start to get into smoking. Nicotine improves focus in ADHD. So people with ADHD tend to start smoking when they're 10, 12 years old because they're self-medicating. And then they get into the pot. Now, ADHD often doesn't really show up till they get to college, because again, they were living at home, and if they had, good vigilant parents, they had functioning prefrontal cortex called their parents, who got them to do the homework and who made sure they got to class and who made sure that they didn't say the wrong things to Aunt Matilda when she came over. That external prefrontal cortex was of enormous benefit. But then they go to college. Now they have to be self-directed. Now the teachers don't care if you hand in assignments or not. They're not like high school teachers who will egg you along and help you get through it. University, they don't care.
No, we don't.
They'll just
I'm
fail
kidding.
you.
We care, but we don't. We're adults.
But you're not writing. You're right.
We don't chase.
You think they're adults. They're not. But that's the point, is you're assumed to be an adult. And that's when people who hadn't been identified before will flame out, because now they can't do it the night before anymore. They can't procrastinate and get it done. So the ones who got through doing night before, morning of, that doesn't work in university and they fail. And then the others who go on into their adult lives, they tend to have marital trouble because they won't stop talking over their partner. Lots of marriages break up because, as a woman put it, I asked how many kids she had. She said 2, 3 if you count my husband. And they get tired of being the only adult in the family. And the marriage breaks down ultimately because the woman gets tired of being the only adult in the room, or the husband gets tired of dealing with emotional outbursts and dysregulated behaviors. So high rates of relationship problems, very high rates compared to others of incarceration. Jails are full of people with ADHD because they couldn't regulate their first impulsive reaction. They did what was their first impulse, and they wound up in jail. I always quote a guy I had, looked just like Hulk Hogan. There, I dated myself. But Hulk Hogan, the nicest guy in the world, in and out of jail, in and out of jail. He came in one day, he says, I hate Hamilton. And I said, well, lots of people hate Hamilton. Why do you hate Hamilton? And he said, because people don't lock their cars. And everywhere I go, all I see is opportunity. And so this poor guy, having no control over his impulses, he'd walk by a car. If it was open and he needed to go somewhere, he'd just get in and boost the car. Or if there was a purse there, he'd steal it. and then he'd go back to jail. And it wasn't evil. He didn't intentionally plan any of these things. He just could control his impulses. So jail's full of these people who lost their temper, went into a rage, couldn't regulate themselves, and hurt somebody or killed somebody. So that's the kind of span. The people who are successful as adults with ADHD, because lots of people are, I see lots of doctors, are people who marry a prefrontal cortex or who have a really good secretary, administrative assistant who is their prefrontal cortex, who keeps them focused on the job. One told me a story, and I'll stop the rambling now with this, but this one doc came in and he said, I came back from vacation and there was a sign on my door that said, I'm on to you. He went into his office and on the computer screen was a sign that said, start left, work right. And the secretary had taken all of the work the guy had to do and had put it in piles based on priority, left to right. So that's the kind of assistant that a person with ADHD needs. And people can do fine if they know, I can't do the detail work. I'm good with the ideas, but I need to delegate and I need someone to keep me organized. So ADHD, traditionally seen as being a problem with three aspects of self-regulation: regulating your attention. The myth is people who have ADHD can't pay attention. It's not true. The problem is their brain is interest-driven. So if they are interested in something, it's stimulating for them, and they can hyperfocus. They can game for hours because it's interesting and it's stimulating. No problem with focus. They can read a book for 3 hours if they're interested in the subject. But if they're not interested, they can't pay attention. And it's been described as erectile dysfunction of the mind. So that if you're not interested in it, you just can't perform. You just can't do it. And then that's seen as just being lazy. But the way their brains are wired, if interested, all in. If not interested, all out. Can't pay attention. So it's a problem of regulating attention. Impulsivity, we all have initial impulses. We all have sexual attractions. We all have the desire to go for a drink and forget the project we're working on. We all have the desire to play instead of working. And the difference is when we have an adult brain, that impulse to say what we think, to do what we want, is dampened down by the prefrontal cortex automatically, so we don't act on our first impulse. When you have ADHD, the first impulse is not automatically buffered and dampened. So you do the first thing that comes into your head. So the worst of that was, I had one person, there was a question, is it bipolar or is it ADHD? Well, if you buy a car to match your purse, that's actually probably bipolar mania. But people do all kinds of weird stuff where they impulsively buy stuff. They have Amazon shipments coming every day because it feels like it'd be a good thing to do, so they just do it. And before we started this session, I said, Rob Ford, I think, was a textbook example of ADHD, adult ADHD. He was highly impulsive, unfiltered, said what he thought, did what he wanted, highly destructible. And you know what? The reality is Donald Trump, too, seems to have terrific ADHD. Can't hold attention unless he's directly affected by it. And it's interesting, highly impulsive, highly erratic, highly restless, can't sit through meetings. We all have the impulse, but our brains naturally keep us from acting on it. When you have ADHD, your brain doesn't automatically keep you from acting on it. So you do all kinds of inappropriate things. And part of that impulsivity is you have emotional impulses. Your emotions swing really rapidly. Somebody says something and it feels hurtful or rejecting. People with ADHD can't regulate the automatic down down drift of their emotions. So they drop into a low mood really quickly, and it's hard for them to get out of it. So their moods swing up and down because, like attention, like impulsivity, they don't have the buffer that allows them to regulate how they react to emotional stimuli. They just react. And the hyperactivity we talked about. So the emotions, though it's not part of DSM criteria, it's always been part of the conceptualization of ADHD. It's always been seen as a core component of ADHD. And the way people describe it is they'll experience an emotion and it owns them, it floods them, it takes every inch of their brain immediately. And so their mood shifts really quickly, and they have a hard time bringing the mood back to where it was, back to baseline. Very sensitive to rejection, easily triggered into anger outbursts, because again, somebody cuts you off in traffic, we all get angry, but we don't act on it. We have the buffer. If you don't have the buffer, you follow that car honking and giving them the finger, and you go into a rage and you get into all kinds of trouble. And people with ADHD have lots of trouble with anger outbursts followed by awareness when their adult brain kicks in that was totally inappropriate, and lots of apologies. So they are really victims of their emotions, and it's exhausting for them to try to control both their attention and their emotional actions all day.
So thinking about all of this then, how does medication actually improve these core symptoms of ADHD? What's the overall goal of treatment with medication?
2 words, dopamine and norepinephrine. Again, the problem is, again, isolating the prefrontal cortex as part of ADHD. The problem in ADHD is underactive, or for all purposes, low levels of dopaminergic function. So the part of the brain that puts the brakes on your behaviors, the part of the brain that regulates your behaviors, doesn't have enough fuel. So when you give a stimulant, you increase dopamine, you increase norepinephrine, and now the prefrontal cortex has the fuel it needs to put the buffer in place. And so when people start on a stimulant, what they'll often describe is, I've just got that moment when I can decide how I'm going to react instead of just reacting. The millisecond, the second of pause, that's what stimulants do, is they give power to the part of the brain that puts the brakes on. And the stimulants help all of the core symptoms of ADHD. They help with the hyperactivity. They help with ability to pay attention. They help with the ability to resist impulses, and they help with the loss of emotional control. So stimulants, these are sort of some of the domains. I won't go into them in detail, but you have trouble with focus and concentration. You have trouble staying with jobs because they get boring, you stop doing them. You have trouble with regulating your emotions, with waiting, tolerating frustration. You have problems, they have very poor sense of time. It's one of the most interesting parts of ADHD is they have very poor working memory. So they'll measure something, and 9 times out of 10, by the time they walk across the room, they've forgotten. They have to go back and measure it again. If you're a pharmacist with ADHD, good luck, because you've got to remember how many you're counting, and then you forget. You have to go back and look again. You keep forgetting what the number is, because that's working memory. And people with ADHD have a very poor sense of time. They don't register time the same way we do, and they have very poor working memory. They have problems, obviously, with 2 things: getting started on things they're not interested in, and stopping things they're doing that they are interested in. They can't regulate it. And of course, they're disorganized. They're always tend to be late. They have trouble prioritizing. It's a weird thing about the ADHD brain is all items on the to-do list when you have ADHD have equal weight. And that's hard for us to understand because we naturally go to, well, this is the most important one. I need to do that first. When you have ADHD, they're all equally important. Your brain doesn't prioritize them. And so people will organize their desk drawer instead of study for the exam because it's equal priority for them and one's more enjoyable. They just don't prioritize. So those are aspects of executive function which is impaired in ADHD. So when people ask you, should I take this medication? You don't know what all their symptoms are, but should you take the medication? Well, yes. Next slide. Oh, sorry. Just keep going because this is it.
Here.
So should you take your medication? Well, you should if, I don't know if the build is there. Is the build there? Yeah. Next one. So yeah, if you want to be able to finish things that you've started, like maybe correct punctuation on your slides. If you want to actually finish things, not just start them, why don't you see if the stimulant helps you do that? If you want to get more done with less effort, that's the most common way people describe it is, I'm getting more done with less effort. Why? They stay on task. They're not having to constantly remind themselves what they're doing. So, yep. Should you take the medication? Yes. If you want to feel calmer and more in control, if you want to be less moody, you should be taking the medication. If you want to not lose things as often, not forget what you're saying in the middle of a sentence, you should be taking the medication. If you want to stay at the job till it's done, if you want to keep your job because don't tell the boss what you think of them, you edit your comments, then you should be taking the medication. And if you'd like to actually be on time or actually get organized and stay organized, then you should be taking the medication because that's what the medication does. Now, it doesn't do all that, obviously, but it helps you do all that. And so the big incentive is it'll help you be better in control of your life. You'll be apologizing less. And if you're a parent, you'll feel better about how you parent.
So I would imagine like in any chronic disorder, there's patients who don't want to take the medications. So as pharmacists, we often fill the prescription, but sometimes we hear the concerns that may not be voiced to the physician who wrote the prescription. I think patients are often quick to oblige to the instructions in an office, and they end up at the pharmacy having a bit of a conundrum. So how do we help folks recognizing all of the things you just showed us that the medications actually will improve? How do we help folks see what the medications may be able to do for them and help bring them along if they're hesitant to get started or hesitant to continue potentially?
Yeah, because it's interesting. People with ADHD are commitment phobic. They don't like to make commitments. They don't like to be locked down. And so I think one of the ways to approach it is to, if they say, well, why do you think the doctor prescribed it? What were you hoping would improve? What was he hoping would improve? What did she think might improve? But I think the key message is, yeah, you don't have to take the medication. It's your call. But it's always the patient's call as to whether they do or don't take the medication. And so again, recognizing that many people with ADHD are contrarian or slightly oppositional, it's like, yeah, you don't have to take the medication. But it might be interesting for you to do it and to see if it does make a difference. Why don't you just do it as a test? Try it out for, whatever, 2-3 weeks and see whether you're getting more done with less effort. See if you feel more in control and then stop it and see if there's a difference. AB trial. I do that all the time with patients. Do it but make sure they've got the proper dose first, but do it and then stop and see if it makes a difference. And also I say, and if you're not sure, ask the people around you. Ask your spouse if they notice a difference, because people with ADHD are not good at self-assessment. And so they may not really notice a difference while the partner does recognize lots of differences. So I would say, don't have to take the medication, but why don't you try it out as an experiment and see whether it actually is of some use to you? If it doesn't work, you stop taking it.
Yeah, I think those things are really helpful. And that patient medication experience, I think, is really important. And so understanding what their concerns are, why they might not want to take it, what they might have heard, anything that we can gather that might be actually leading to the hesitancy, to help debunk myths possibly, or experiences that other people had on the medication. I find if you spend a few minutes with those questions, you get a lot farther, because that experience is going to drive what they do when they leave our site at the end of the day.
Yeah, absolutely. Why are they hesitant? That's exactly the main question, is what are your worries? I'm going to get addicted. Well, you don't get addicted to stimulants. You know, they work. And if you stop taking them, you'll have the symptoms back again, but that's not addiction.
Yes, it
Why
leads
should
us
you?
into
Yeah, why should you take the
nicely.
medication? Well, I don't know. Should a diabetic take insulin? Should somebody who's short-sighted wear glasses? Should an orchestra have a conductor? Because that's what the medication is about. And I like the glasses example. You know, if a parent is hesitant to fill a prescription for their kid, it's important to recognize this is a neurologically based problem. And if your kid couldn't see, would you say, look, you just need to try to see harder? You're just not trying to see hard enough. You know, if your brain is wired a certain way, it doesn't matter how hard you try, you need help with it. If your body is fundamentally has a certain physiology, it may need help. That's why you should take the medication. And again, see if it helps, you see better. That is, see if it helps you be able to focus. See if it helps. If it doesn't, it doesn't.
I think that fear of addiction is actually a huge challenge when it comes to medications, like the stimulants specifically, but other psychotropics as well. And I think that we use the term addiction very colloquially. We use it, we're addicted to all sorts of things that from a medical perspective actually aren't factual. And that notion that we need or depend on something being directly related to addiction in sort of a colloquial way makes sense to people, but from an actual medical perspective is not the only factor that determines whether or not somebody is technically addicted to a substance. And so even having those conversations to help people understand that it's not just about having a physical dependence or a need for a medication that defines whether or not somebody will develop or has a substance use disorder.
And would you say people are addicted to insulin? I mean, you wouldn't.
Never.
And you wouldn't, but it's a hallmark of psychiatric medications that suddenly you start using the term addiction when it's
the stigma piece.
Exactly.
So lots of work for us to do there as well.
Yep.
So in terms of untreated adults that might be walking around with ADHD and at our pharmacy counters, I think we've already talked about this a little bit, how we can identify them. And you've talked about the screeners that we can do when we engage in conversation, looking for folks that aren't responding to potentially several serotonergic drugs for depression and anxiety. So is there anything else that you
Well, if we just flip ahead,
for?
there's certain kind of presentations that you might be looking for in person when they come to the counter. The first is, next slide, is obviously if they have a son or a daughter with ADHD, then either they have it or their partner has it. You know, they're the people, because they don't have a sense of time, they don't plan ahead. They're always going to call for their prescription renewal the day it runs out or the day after it runs out. So the renewals are generally overdue because they forgot to take their medication several days. They forget to pick up their medication because, again, it was really important at the time they called, and then they got distracted, they did other stuff, and they never came to pick it up. Next. When they come in, their hair is a different color again. And I'm constantly looking for something novel, something new, something stimulating. And at the counter, they're very commitment phobic, as I said. So they won't just take the medication, but they're anxious. They overthink every aspect of the medication, but what about this? But what about that? So it presents as as anxiety, but that's also how ADHD presents, is they overthink things horribly, and they have a hard time actually just making the commitment and going with it. So they'll ask millions of questions, and they're scattered and forgetful. They will have left their wallet at home. They will be digging around in their purse, trying to find their wallet or trying to find their card. They'll have lost their credit card. They'll have lost their, the record so far is 26. The most I've had any patient is they lost 26 credit cards.
Wow.
And if they've lost it again, how often have you lost it? Oh, I lose it a lot given the ASRS, because they forget stuff and they lose stuff because they're not paying attention. And the other is they impulsively buy. So if the prescription is being filled, they buy a lot of stuff while they're waiting. And especially, sorry, but if it's a woman, a young woman, they tend to buy a lot of makeup. So they're going to be cashing out with a big basket. That isn't to encourage you to take a long time to fill the prescription. And again, the emotional part, they get really frustrated if you take a bit of time to fill the prescription. They hate waiting. They can't stand waiting. They're impatient. They may burst into an angry outburst or a rage. They tend to talk, and when you try to explain something, they just talk right over you and keep going. They don't listen. And when you do give instructions, they forget them right while you're giving them, and you'll have to repeat yourself 2 or 3 times. You know, a good test for ADHD, although it can happen with depression, is when you've given a couple of simple instructions, just say, repeat that back to me. ADHD, they won't remember what you just said because they weren't paying attention and they don't have short-term memory. The main thing, sign that it could be an ADHD patient, is if you have the urge next to say, grow up to them. Or if you have the urge to say next, act your age, because that's the essence of ADHD. That part of their brain hasn't fully grown up, and they're not acting their age. They're immature and they're acting it. So that kind of customer, be thinking, could this be ADHD? So stimulants, we can go through this fairly quickly. You guys know your job. When we're giving the stimulant, as I said, what we're trying to do is get an adequate level of catecholamine in the prefrontal cortex and allied regions. When you give too little, it doesn't really have much effect. When you give too much, people get jittery, nervous, anxious, or their mood drops because they're in noradrenergic overdrive. But the key thing is this, and it's the biggest single misunderstanding about stimulants. When you have ADHD, stimulants are calming, they're not stimulating. So you don't feel caffeinated with the first dose or second dose. If you feel caffeinated, it means the dose is too high or you've got the wrong diagnosis. Because the stimulant, again, is increasing activity in the part of the brain that calms you and puts the brakes on. And pretty much universally, when a person takes a stimulant, that's what they feel. Their head is less busy, they feel calmer, they can get more done, they have fewer distracting thoughts. But it isn't the pumped up cocaine high, it's the absolute opposite. And in fact, interesting note, I always ask people how cocaine affected them. Of course, 80% of people look shocked and say, I've never done cocaine. But it's an interesting thing that people with ADHD, it's quite common that when they do cocaine, it calms them down, and it's not rare that they then go and do the laundry. They just go and tend to business because they're getting a big hit of dopamine, which is what they need to be able to focus and get jobs done. And of course, you know, the effect size for stimulants is much higher than for non-stimulants. I do use atomoxetine, Strattera. I use bupropion sometimes, but the money's in using the stimulants. The effect size is the highest of anything we use in psychiatry. They're remarkably effective, but stimulants and always long-acting.
So how do
So,
patients know if their drugs are working? And you've got some slides that will help pharmacists gauge.
yeah. So the first week, usually or often they don't really notice a difference, because if they're just on 10 milligrams of Vyvanse, for some people they notice a difference with 10 milligrams, but for lots of people they won't really notice a difference. So they may not notice anything. If they do notice anything, again, they'll feel calmer. They'll notice that they're not as short-tempered. They're less frustrated and less moody. And people often describe that instead of having 10 thoughts in their head at once, they now only have 2 or 3 thoughts competing for their attention. The beehive brain is settling. They have fewer competing thoughts. Obviously, in the first week, even you can start to get the problem with loss of appetite. When you get to the second week and third week, because usually the prescriptions, they should be increasing the dose each week. They should, again, feel calmer, again, feel less frustrated, less busy thoughts. By the second, third week, they may start to notice they're getting more things done, because it's not always obvious. It can be a quiet effect where they realize at the end of the week, wait, I got a lot more done this week and I'm not as tired. And the other thing is, you know it's working by the second or third week. As the dose goes up, they'll notice that when the medication wears off, their brain starts to get busy again, they start to get irritable again, and they're having all the old problems with focus, attention, and moodiness. So if they're not sure whether it's working again, ask them to check with their family and friends whether they notice a difference. One more time, people with ADHD are very bad at self-report. They're not accurate. They tend to not remember well what happened through the week, and they tend to simply play back how they feel today as if that's the way they've been for the last 2 weeks. The duration of control is extremely important and extremely misleading, as published. So duration of effect for stimulants is based on doing pencil tasks like mathematical problems. And if you're doing mathematical problems, you know the duration of effect for the long-acting medications. It's between 9 and 12 hours, Foquest as high as 16. This is not accurate at all, because people, the effect of the stimulants is not just on being able to do concentration tasks. It's on overall self-regulation. Again, it's on controlling their moodiness. The reality is bifentin, for most people, lasts 5 or 6 hours before they're sliding back into their dysregulated behavior. Concerta, for most people, lasts around 7 or 8 hours. Foquest does tend to last the full 16. Adderall is about 6 hours, and Vyvanse is around 8 up to 10 hours. But the reason it's really important to recognize that is people prescribing think long-acting means it covers them for the whole day, and it doesn't. They take it at 8 in the morning. It means by dinner time, they're back to their old ADHD selves. And in the evening, if they're a parent, they need to be in control. They need to know, they need to be acting like a responsible adult parent, not losing their temper, not going out to hang out with the buddies again. So it's very important that ADHD be controlled into the evening. If they're students, they need to be able to study in the evening, not just go to classes and pay attention. They need to be able to study. So really important as pharmacists that you check with them, is this keeping its effect for you through the whole day? Is it still helping you in the evening? And the reality is most of my patients on long-acting stimulants need BID dosing. Now, there's 2 strategies when it wears off. One is you give a short-acting stimulant for the evening, or some people prefer short-acting in the morning because it comes on board faster, long-acting then for the rest of the day. I tend to use long-acting in the morning it's around 8 o'clock, and then a second dose of the long-acting, usually half to 2/3 the morning dose in the early afternoon. And that usually then will carry them through the evening. But it's important that they recognize when it's wearing off and they go back to their doctor and get coverage for the whole day. And I've just gone through that. And I went through that earlier. It's too high when you're edgy, sketchy, and nervous.
And so these are just questions that we put in. So I'll bring it to Ruth because we have questions I can see. So we'll leave it at that and open, I think, the floor. I'm going to stop sharing my screen.
Okay, thank you so much. Yes, we do have a lot of questions.
Awesome.
So,
Good.
but this one's kind of a long one. I'm a pharmacist at an academic family health team. Our family docs collaborate with shared care for psychiatry regularly. At a recent education session on ADHD, family docs raised concerns about long-term stimulant prescribing and made an analogy to opioid overprescribing. Psychiatry seems less worried about this, but the specialist lens often differs from primary care. Do you have any data around rates of stimulant misuse or abuse in the adult ADHD population?
We don't have good data. Most of the data on stimulant use and abuse is in college populations. And there, there is some abuse and use, obviously, for studying purposes, to stay up and be able to cram the night before. That's why any students I have, I say, do not let other people know that you have stimulants, particularly if you're in the dorm, because they'll be pestering you come exam time to give them your stimulants. So just don't let them know. But the stimulus abuse in adults is, on the whole, very small. You know, you're not going to, especially the long-acting stimulants. Why in the world would you take Vyvanse to abuse Vyvanse? It comes on board slowly. You don't get any rush from it. And that's what people are after when they want to abuse stimulants. People want the short-acting compounds when they're abusing stimulants. So a sign that somebody might be abusing a stimulant is they insist that only Adderall works, although for many people only Adderall does work, or only short-acting dexedrine works. For some people it's true, but for most people the long-acting gives the most consistent effect and they're happy with it. So I think the biggest problem we have in treating ADHD is people are preoccupied by the potential for stimulants being rerouted, being sold, being abused. And the result is we don't treat the majority who need the help with their ADHD. So, you know, the worst maxim in medicine is above all, do no harm. For me, it's like go out there and do lots of harm because it means you're trying and it means you're not practicing a super conservative practice. You know, it's better to make a mistake where one person a year, two people, it turns out they're using the drug inappropriately. It's better that two people get drugs that are inappropriate than 90 people not be given drugs they need.
I wonder, Jamie, with your experience with childhood ADHD, is there a benefit from holidays, such as during summer holidays, etc.? Maybe you could step on that.
Yeah, this is a really trendy thing, and certainly I've had a lot of experience where parents want it. Particularly, I think it goes back to the misconceptions around stimulants and what they do in an ADHD brain versus somebody that doesn't have ADHD. And so I think parents are often worried about the potential for abuse or addiction or those kinds of things. And so taking the stimulant away for periods when the kids aren't in school, March break, summer holiday, sometimes I've even seen it on weekends. So they take it Monday to Friday and then not on Saturday and Sunday. The problem with that, and where I have had conversations with parents, is that's treating mom and dad that probably don't have ADHD, or maybe one of them does, but it doesn't do a lot for the kid who still actually needs to be able to socially interact with the world, even not at school. And so again, when you think that the child with ADHD needs the stimulant, and you wouldn't withhold their glasses on the weekend. I like the glasses as well. Just because they're not in school, they still need to be able to read. I'm not sure that I would recommend stopping. I certainly have had patients or parents that are really adamant and they've decided to do that. But those kids struggle at camp. They struggle with interacting with their siblings. There's more fights. They're more irritating. They get yelled at more at home when they're not on their medications because their behavior and their impulsivity is harder to manage. So yes, people do it. Yes, there is some evidence to suggest that it can help with appetite. So where I've seen benefit are in the kids that have lost a lot of weight and they're not eating enough and they need the summer to be able to not have their appetite suppressed so much. But beyond that, there's very limited benefit and it's potentially harmful to the kids to stop them. Or that's my bend on it, having worked in this area.
Yeah, what she said.
You did touch, Jamie, on the weight loss thing. When I know that parents worry about that, and especially in a growing child and a younger child, maybe you could talk a little bit about how to either reassure or when it's a matter of, you know what, you need to speak to your doctor about that, or this, you have a legitimate concern here. Maybe you could talk about that.
Well, for sure in kids, I guess this is a bit different, particularly because they're growing. And so the appetite suppression and weight loss and those things impact growth. And obviously we think a lot about whether or not these agents have an impact on overall height and growth as well. And that data is actually, the impact is quite low overall. That said, what you try to do is make sure that you get a baseline weight before you start the stimulants and you have a sense for the weight that your child should be at within, obviously there's charts and things, particularly for younger kids. But get a baseline weight, check it periodically so that you can actually see what's happening consistently at the same time, and frequency is helpful. And then we usually work with the families, and sometimes dietitians are needed. It depends on the case, but you try to make sure the kids have their biggest meals when the stimulants are at their lowest ends. So big breakfast before they have their morning dose. Sometimes they're hungrier at dinner as the dose is wearing off, or in the afternoon before they take the next one. But it's trying to find ways to maintain healthy eating around sort of the peaks and troughs of the stimulant, I find to be the most effective. Most kids lose their appetite but still eat in general, and so weight loss is not hugely problematic from a health perspective for most kids that require specialized dietitians or different medications. But many kids do experience that feeling of not being hungry. That's just part of the deal in general. But I feel like we talk about it a lot, and it's not necessarily as big an issue as we make it out to be for the vast majority of folks once they get used to it and in a rhythm. But I don't know if adults would be different.
Nope. Again, what she said. But basically it's people do lose their appetite, and the key there is just what you said: big protein rich breakfast before the stimulant has come on board fully. Snack on protein bars or protein rich stuff through the day, and then have a bigger meal again at the end of the day when it's wearing off. Although again, that doesn't mean necessarily dinner time, because the medication shouldn't be wearing off until into the evening. But the real important is protein, hydration.
Yeah, I find that one of the most beneficial things a pharmacist can do, people read side effects and they hear things and they think that it means a side effect means that there's something wrong with the medication and that there's some problem here. And I think to give people and the parents options and say, no, this is something expected. It's not a bad thing, but we can take care of it. I think it's one of the things that you can really impart on patients, that so they can handle this. They can handle these things and continue on with their medication. Just my 2 cents.
Absolutely.
If I can address one of the common, not quite myths, but almost, is people are really worried that stimulants will keep them up at night. And the reality is most people with ADHD, stimulants don't keep them up at night. again, they're calming. When the stimulant wears off, their head gets busy again. They have trouble getting to bed. Then they have trouble getting to sleep because their brain is too busy. And although it sounds, and I had a pharmacist fax me about it, and it was appropriate fax, but I have several patients who take a small dose of dexedrine or Ritalin at bedtime because the stimulant has worn off. Their brain is too busy. They can't get to bed and they can't get to sleep. And a small dose of stimulant at bedtime, again, it's calming. So it reduces all the noise in their head, their busy thoughts, and they can get to bed and get to sleep. So that isn't necessarily a prescription error, but it's, again, recognizing stimulants are calming, not stimulating.
Right, in the proper diagnosis, obviously. Someone asked about the use of bifentin in patients with GAD.
So, yeah, and the problem is that people with anxiety disorders have high rates of ADHD and vice versa. And so generalized anxiety disorder is very common in ADHD. If the ADHD is clearly there based on their executive function, based on the report cards that say not working to potential, needs to pay better attention, all that stuff as kids get moved to the front of the class. God forbid, I had two people whose teachers cut the front panel out of a box and put it over them so they would pay attention. But if they have clear ADHD, this would be a case where I would try the stimulant and see whether that's all they need, because stimulants in ADHD generally reduce anxiety. I mean, I talked this morning, senior hospital administrator, and she's kind of freaking out right now, not just because of the fourth wave, but she's moved, she's got a new partner, et cetera, et cetera. And her anxiety is really through the roof. And I had to remind her, remember, are you taking Vyvanse in the afternoon? And she said, no, I'm too busy. And so it's like Vyvanse for her markedly reduces her anxiety because her brain is able to stay on task, et cetera, et cetera. And so counterintuitive, you'd think Vyvanse or any stimulant would worsen anxiety. If you have ADHD, stimulants generally reduce anxiety.
Excellent. Well, we've run out of questions. And so unless you have some parting words, I want to thank both of you for an excellent presentation. I know so much more about ADHD. I also want to thank Rachel from Takeda for their support of this evening. I feel I really like that stimulant at bedtime thing. I'm going to take that home with me, because last thing you want is bothering a doctor. He's like, but I can just imagine that the look on my face would go, what's wrong with this guy? What do you work over? Do you work like a midnight shift? Or anyway, so it was very helpful. Thank you very much, everybody, and have a great night. Bye.
Thank you very much.
Thanks, Ruth.